Is it true that 90 to 95% of hypertension cases have no known cause? For decades, we have taught that 90 to 95% of hypertension is essential or idiopathic, which means that its cause is unknown. But is it truly unknown, or have we simply failed to connect the dots? Over the past decades, growing evidence has highlighted a unifying metabolic disorder, a disorder that links insulin resistance, prediabetes, type 2 diabetes, non-alcoholic fatty liver disease, dyslipidemia, polycystic ovary syndrome, central obesity. These conditions do not coexist by chance. They share a common denominator: chronic hyperinsulinemia. Let us begin at the root. Insulin resistance means that tissues, muscle, liver, adipose tissue, do not respond properly to insulin. To compensate, the pancreas secretes more insulin. Blood glucose may remain normal for years, but insulin, meanwhile, is already elevated. And chronic hyperinsulinemia is not benign. Insulin is a powerful hormone, not only metabolic, but also vascular. Now let us speak about blood pressure. How does insulin increase blood pressure? First, the kidneys. Insulin promotes sodium retention. More sodium means more water. More water means higher plasma volume. And higher volume means higher blood pressure. Second, the sympathetic nervous system. Hyperinsulinemia activates it. Heart rate increases, peripheral vessels constrict. Blood pressure rises. Third, the endothelium. Insulin resistance reduces nitric oxide production. Nitric oxide is necessary for vasodilation. Without it, arteries become stiff. They lose elasticity. Peripheral resistance increases. Fourth, insulin acts as a growth factor. It stimulates vascular smooth muscle proliferation. Arterial walls thicken. Resistance increases. This is not random. This is not mysterious. It is hypertension of metabolic origin. Now let us look at the broader picture. Type 2 diabetes. Chronic insulin resistance gradually exhausts the beta cells. Hyperglycemia appears. Dyslipidemia. Insulin resistance increases hepatic VLDL production. Triglycerides rise. HDL decreases. LDL particles become smaller and more atherogenic. Non-alcoholic fatty liver disease. Hyperinsulinemia stimulates de novo lipogenesis. Fat accumulates in the liver. Polycystic ovary syndrome. Insulin acts on ovarian theca cells. Androgen production increases. Ovulation becomes irregular. Amenorrhea may occur. Central obesity. Insulin is an anabolic hormone. It promotes fat storage, particularly visceral fat. And visceral fat worsens insulin resistance. A vicious cycle, and yet what do? We treat each condition separately. Hypertension, ACE inhibitors. Calcium channel blockers. High triglycerides, statins. Hyperglycemia, glucose-lowering medications. PCOS, oral contraceptives. Fatty liver, general advice on weight loss. Each treatment may be necessary, but none directly addresses chronic hyperinsulinemia. So what happens? We control the numbers, but the engine keeps running. This fragmentation leads to polypharmacy. More pills, more side effects, but persistent metabolic dysfunction. What if instead we considered all these conditions as different expressions of the same disease? A metabolic dysregulation driven by insulin resistance. When we reduce insulin levels, we target the root. Carbohydrate moderation, reduction of ultra-processed foods, weight loss, physical activity, improved sleep, restoration of metabolic flexibility, some medications, such as metformin, GLP-1 receptor agonists, and SGLT2 inhibitors, also move closer to the root. But the conceptual shift is essential. Let us be clear. Not all hypertension is caused by insulin resistance. Genetics matter, kidney disease matters, endocrine disorders matter, aging matters. But in the modern context of metabolic disease, hyperinsulinemia appears to be a major driver of what we still call essential hypertension. Perhaps the word idiopathic does not mean unknown. Perhaps it means unexamined. Instead of speaking of hypertension, diabetes, fatty liver disease, PCOS and dyslipidemia as distinct entities, we could begin to see them as different faces of the same underlying metabolic disorder. For decades, we have said that essential hypertension had no identifiable cause. But physiology is rarely random. If chronic hyperinsulinemia lies at the center of this web, then our strategy must evolve. We must go beyond treating isolated biomarkers. We must treat the metabolic root, not because it is controversial, not because it is trendy, but because biology demands coherence. Perhaps the time has come to reconsider whether essential hypertension is truly essential or simply misunderstood. Thank you for your attention. We invite you to subscribe, share, comment, and like this channel. Meddling Talks is a channel that brings you simple yet lasting solutions so you can live happily.